As Tony mentioned, I'm going to be talking about insurance market reforms, individual responsibilities, employer responsibilities, the Cadillac plan tax, and then industry-related issues. I'm the only non-attorney speaking this morning, so I don't know if that's going to be a good thing or a bad thing, but I feel good sitting at that table over there with all those gentlemen. But as Bob said, my background is more on the financial side of things and the insurance side of things. So we're going to project ourselves now to it's 2014. The first thing I want to talk about are what are the insurance market reforms that will be impacting both fully insured and self-insured plans. We know that there was a good mix in this room of all sizes of companies and funding mechanisms. The first is no pre-existing condition exclusions or limitations are now permitted. And then secondly, no discrimination based on health status, which are the same rules that currently exist under HIPAA are included under the PAPICA. A little note here, which I think, again, probably through maybe you've been going to other seminars or reading materials, but something of intrigue here for those of you that do have what I'll call active or robust wellness programs in place. There is going to be a change in that maximum incentive amount. If you do have a wellness program in place, you're probably used to a 20% differential, maybe, where you could provide an incentive for people to participate or achieve a health standard in your wellness. That is going to be expanded to 30% of what we call the COBRA cost or your insured cost, with leeway to increase percentage to 50%. We really don't know what leeway means yet. That will be determined by the Secretary of Labor, Health and Human Services. So again, looks like there will be some changes in terms of the incentives that you'll be able to provide under the wellness program. The next slide, again, fully insured and self-insured post-January of 2014. Tony kind of touched on this a little bit too. No discrimination against a provider who is acting within the scope of his or her license is permitted. It doesn't necessarily force a plan to contract with every willing provider or any willing provider. There's been around the country some states that have had that type of legislation where a network or plan has to take any provider that meets qualifications. It's just saying within the panel there would not be any discrimination against such a provider. Certain cost sharing requirements. This slide is going to give some people with high deductible health plans a little bit of a shock. There are certain cost sharing requirements that must be satisfied so that the out-of-pocket expenses do not exceed the applicable to HSA related coverage. Now this next sentence, again, where it says, and deductibles do not exceed $2,000 for single and $4,000 for family coverage. I know a lot of you have a deductible that's above that today. Well, what we don't know, there's some correspondence and documents that say that's just applicable to small employers, but then we've seen conflicting where it's applicable to all employers. So we do not know the answer to that yet. We got an opinion yesterday from Health and Human Services that they are still making that determination. So for those of you with a deductible above that amount, that is something we'll be obviously monitoring very closely. And when we get to the Cadillac plan tax, it seems kind of backwards where now you're forcing me to improve my plan under health reform. Well, in a way, that certainly could be the case with these deductible requirements. So we're keeping a very close eye on that. We'll obviously keep you informed once that opinion is complete. Next, plans may not impose a waiting period in excess of 90 days. Some of you may have 6 months, things like that. The legislation says 90 days. A good question I've had from a couple people, well, would that mean you have 90 days and then first of the month following 90 days? Our understanding is 90 days is 90 days. So if your plan has a waiting period longer than that today, that would have to be adjusted. And a plan may not deny qualifying individuals' participation in certain clinical trials or deny the coverage of routine patient costs for items and services furnished in connection with the clinical trial, another component of the legislation. So now we get into what we call individual responsibility. Again, a lot of discussion, effective in 2014. So, a very common question if you're all employers is what happens if employees don't enroll in our plan or we're offering an employer plan. So an individual at the time who does not enroll in qualifying coverage, qualifying employer-sponsored coverage, must pay an excise tax. The greater of, and you can see $95 in 2014, goes up to $325, and then to $695 in 2016 and thereafter. It's the greater of that, or percentage of income equal to 1%, then 2%, and then 2.5%. Families will pay half the amount for children up to a cap of $2,250. Then after 2016, again in the legislation, it just talks that there will be the amounts will increase by an annual COLA, or cost of living adjustment. So now you're getting into, so what happens if if individuals are not enrolling? There are going to be penalties. From a risk standpoint, the concern of people paying a penalty in lieu of maybe participating as well, if the penalty is not tough enough or high enough to make people participate in plans, you get into anti-selection. So they only participate in plans when they actually need the insurance coverage, covering your burning house, or after your car accident you go buy your insurance policy, those types of things. So that's a risk concern, which is really the crux of a lot of things that we talk about, impacts to cost and price, which I'll mention at the end. That's a big one that we haven't been able to quantify yet, what that could be. Going to the next page, then we get into what's called vouchers. So employers that offer this minimum essential coverage and make a contribution must offer what's called free choice voucher to qualified employees for the purchase of qualified health plans through the exchanges. The free choice voucher must be equal to the contribution that the employer would have had made to its own plan. Employees qualify if their household income does not exceed 400% of the federal poverty level, and required contributions under the employer's plan would be between 8 and 9.8% of their income. So the next few slides are going to get into some, now we're getting to calculations. Well, what does this mean? We'll certainly have calculators or worksheets available to help assist if this would be the case. The free choice vouchers are excludable from the employee's income to the extent used for health care, and then deductible also by the employer. And then the voucher recipients are not eligible for tax credits through the exchange. So again, if you step back for a little bit, employers that offer minimum essential coverage, you could still have people based on their income levels that would be eligible for these vouchers, and then the employers would still have to contribute to that cost. So with as an employer, your responsibilities in 2014, from a reporting obligation standpoint, we'll have to confirm that you offer or do not offer the minimum essential coverage to the full-time employees and their dependents, the length of the waiting period, which we talked about, the 90 days, what the lowest cost option in each enrollment category under the plan is, employer's share of the total allowed cost of benefits provided under the plan, and then the total number and names of full-time employees receiving health coverage. So Tony said it's a boom for the insurance industry. I think it's going to be a boom for the payroll reporting industry too. There's going to be a lot of reporting requirements starting in 2014. There's generally no requirement for employers to offer the same coverage that insurers offering coverage in the exchange must offer. In fact, there is generally no requirement for employers to offer any coverage, but however, for those of you that have more than 50 employees, again, will be subject to certain penalties, which we'll talk about, related to coverage that they offer or fail to offer to the full-time employees. So if you don't offer coverage, there would be some tax or penalties that will be applicable, which we'll mention here. We're on employer responsibility, the small business incentive. So here, beginning in 2010, as the law provides for some tax credits for qualified small employer contributions to purchase coverage for employees. So if you're in this room a small employer, you want to pay attention to this. The maximum credit is 35% of premium paid in 2010 by eligible small businesses and 25% of premium paid by eligible employers that are tax exempt. So there is a difference if you're a tax exempt organization. In 2014, the maximum credit jumps to 50% of premiums paid by eligible small employers, and then 35% of premiums for those tax exempt organizations. This applies to small employers with fewer than 25 full-time employees and average annual wages of less than $50,000 that purchased health insurance for their employees. And then this last bullet here on the maximum credit, really what that means is if for employers with less than 10 and average annual wages of less than $25,000, you're going to get that maximum, the 35%. So it'll be a scale, again, depending on where you fall as a small employer. Of more than 25 employees whose average annual salaries exceeded $40,000. So a real easy example, in the 2000 tax year, if you have 9 full-time employees, average annual wages are $23,000, and then say it's averaging about $8,000 of cost per employee. So your premiums for the year are $72,000 for those employees, and just it basically means it's qualified. Then the credit would be $25,000, 35% times $72,000 of premiums. So again, some incentives to continue providing coverage, so that there isn't a mass exodus of small employers in the health insurance pool. Back to 2014, for employers, the play or pay mandate. So those of you now that have more than 50 full-time applicable employees are going to be subject to some penalties. Any employer who fails to offer any full-time employee health coverage must pay a penalty with respect to each full-time employee in any month in which any employee receives a federal subsidy for the exchange that Tony talked about. So I know this is kind of small in your paper, but the penalty is determined on a monthly basis and is the product of the total number of your full-time employees at the employer. The first 30 are exempt. Again, I'm not sure how they came up with this, but you take your number of full-time employees minus 30, and then it's 1/12 of $2,000 on a monthly basis would be the penalty. So for example, if you have 51 employees and you do not offer coverage, you are subject to the tax equal to 21 times the applicable payment. So 51 minus the 30 exemption. And that's been a common question. As an employer, you might say, well, why should I just pay the penalty? Should we offer health insurance? Well, and again, these are some of the things that are being put in place to provide incentives for employers to provide coverage. So continuing on with this, the player pay, part-time employees are taken into account solely for the purpose of determining if employers are at that 50 level. And then the number of full-time employees otherwise determined is increased by dividing the aggregate number of hours of service of employees who are not full-time employees by 120. So back to the, yes, we will have some calculators and helpful tools for you to take that calculation into account. Next slide, continuing with the player pay mandate. So applicable employers who impose a waiting period of more than 90 days must also pay a penalty. It'd be $600 for each full-time employee to whom the extended waiting period applies. So we certainly anticipate those waiting periods to change. We'll do the math, obviously determine the cost of that versus paying the penalty. Even when coverage is extended, applicable employers who offer coverage for any month to a full-time employee who is certified as having enrolled in the exchange and received a tax subsidy is subject to a penalty equal to the product of the total number of employees who have received a tax subsidy and 1/12 of $3,000, capped at 1/12 of $750. You can see the formula. This is in the law, unfortunately. So this is just saying, so even if you're offering coverage, if you have employees who's part of the exchange and receiving a tax subsidy, there will still be a penalty applicable to you. So one note down here, employees offered employer coverage are not eligible for a credit unless the required premium exceeds that 9.5% of household income, or if our plan does not meet that 60% actuarial value. And again, we'll, by 2014, so this isn't one of those immediate impacts that Tony talked about, but there'll be a lot of testing done as we get close and determining what could happen. I've heard a lot about this term, the Cadillac tax, beginning in 2018, so we're really progressing ahead many years. This did get a lot of attention before Congress passed legislation. You might have heard some stories with the unions lobbied hard, because when you think about this Cadillac tax, most people think about, well, it's just for real high-income, wealthy individuals. Well, not necessarily. A lot of school districts or maybe with labor organizations that have a real competitive or very good benefit plans, we're also going to be impacted. So this got pushed to 2018, and PAPICA, what they said is there's going to be a 40% excise tax on coverage providers, and we'll define that here in the next slide, for the sum of months in which the aggregate value of employer-sponsored health coverage for the employee exceeds $10,200 for single. So if you take your single premium or COBRA equivalent premium times 12, most clients today are not, we're not near this 10,200, but keep in mind this is 2018. And then for family coverage, $27,500. So today it'd be a ways to go for all of you. Again, I'm not aware of anybody there might be some getting close, but we'll have to address that. The higher family threshold applies to both single and family coverage offered through a multi-employer plan, which probably won't be applicable for most of you. So the excise means, so the value above these amounts is what would be taxed at the 40%. So if it's $11,000, $800 times 40%, that would be the tax. Now, what could happen, though, and Tony made a little bit mention of this, is certainly the Secretary, this could be adjusted if health costs increase by more than anticipated before 2018. Certainly, I don't think anybody would disagree in the legislation. There really isn't anything in here that's going to lower our costs on the health insurance. For the most part, things are going to be priced upwards. So those dollars may change as we get into the next 3-4 years. It may be bumped up. Then the thresholds after that are increased by the CPI +1 in 2019, and then by the Consumer Price Index thereafter. The employer, you may make an adjustment to reduce the cost of plans when calculating the tax if the employer's age and gender demographics are not representative of a national average. Again, we're not sure what that means exactly yet, but that is one part of the legislation. And then there was some talk about a transition rule for high-cost states, but that does not apply. And Nebraska certainly, or Iowa or South Dakota, would not be considered a high-cost state. Probably very few anymore, but still offer retiree coverage, because that certainly adds to your health care costs. The annual limit for retirees between ages 55 and 64, individuals engaged in certain high-risk professions, law enforcement, EMT, longshoremen, construction workers, and miners. And then those employed to install electrical or telecommunication lines those are bumped up to $11,850 and $30,950. So a few exceptions that were granted for those particular groups. Okay, so with this tax, it's determined by the employer and assessed against these coverage providers. So what's a coverage provider? That's a term. Well, it's really either the fully insured plan, so the insurance carrier that provides the coverage. What does include the HSA or medical savings account. I don't think anybody probably has an MSA anymore, but it does include the HSA, the contributions that the employer is making. And then if you're self-insured, there'd be the administrator, the third-party administrator, which if you're self-insured, really that just gets, I'm sure, just passed back through the self-insured plan. So it's applicable to everybody. In many cases, employer-sponsored coverage will include both fully insured and self-insured contributions, may also include the HSA. And again, really the intent here is the tax would be the 40%. Any of the value above those thresholds we talked about earlier, it's 40% of that. And by then, obviously the logical decision will be we'll adjust benefits, do what we have to do to avoid the excise tax, unless, of course, they're negotiated type benefits. But there's enough time, I assume, those of you with the unions, when those contracts are up, that those discussions will take place to make sure that that doesn't happen, or if so, how those costs are paid. We kind of talked about this. It's the applicable premium determined in accordance with COBRA rules for all accident and health coverage provided by the employer, even those with after-tax dollars. There are some exceptions. Vision, dental should be on there as well, long-term care, and then some of the after-tax funded hospital indemnity or disease coverages. So for a while there, they were throwing in like vision and dental as part of the calculation, but those are now not included. Both non-elective and salary reduction contributions to an FSA are included, and then employer contributions to the health savings account if you offer one of those today or in the future. The last two slides I'm going to talk about minimum loss ratios. This starts in January of 2011. Creates a minimum loss ratio requirement that applies to all fully insured plans. Here's another area of potential confusion is, well, if you're self-insured, does that apply to you? Well, if it did and you had an issue, well, you just pay yourself back. So really it's applicable, what we're seeing is to just fully insured plans, including the grandfather plans that Tony talked about. The loss ratio is 85% for large group and 80% for individual and small group plans, 100 and below. How a loss ratio is calculated, the simple definition is you take what paid claims were divided by the paid premiums. So if it's 85%, so 85% of every dollar was used for claims, and then 15% used for expenses, risk charges, those types of things. Well, again, really from being a financial person, a lot of questions, well, where would disease management or case management fees apply? Is that more of a claim or is that an expense? So there's still some definitions we need to understand when this calculation is made to know how that loss ratio is calculated. So what it does is it allows the Secretary of the Health and Human Services to make adjustments in the percentage if it proves to be destabilizing to the individual small group market. But it's saying the insurance carriers have to meet these loss ratios. And I think you've probably heard stories where there's some large rate increases. I think if you're in Iowa, yesterday in the Des Moines Register, an article came out where Blue Cross Blue Shield or Wellmark got approval for their rate increase. In California, this happened where they asked for very large rate increases. What's going to happen is the secretaries, even at the state level, but even at the federal level, there's going to be a lot of scrutinization of if large rate increases come across, especially in the individual small group market, to justify those rate increases. What are your loss ratios, trends? What are the things that are impacting costs overall? And what it means is if the amendment creates a premium rebate to individuals for plans that fail to meet the minimum loss ratio. So if the loss ratio is 75%, and is that loss ratio just your loss ratio or across a pool? Again, some of those clarifications. Technically, a rebate would come back to individuals. So the plan, I don't know, again, to get down to the individual level may be difficult. So it's just saying if you're on the insurance company side, they're dictating what you have to pay out in your expenses and what needs to be used to pay claim dollars. And it gives the Secretary of the Department of Health and Human Services, in conjunction with the states, new authority to monitor health insurance carrier premium increases starting this year. And that's certainly what we're seeing in California, Iowa. I forget the states, a state in the Northeast, another scrutinization. Tends to be, right now, seems to be more on the Blue Cross Blue Shield side, but coming in and really making them justify their rate increases. And carriers that have a pattern of unreasonable increases may be barred from participating in the exchange. So that would be, again, another penalty. The concern is prior to a lot of the legislation hitting in 2014, and this is where I want to end off with from a pricing standpoint, what are all of us expecting to see for price increases? And I know there's some initial models coming out, but what I'll tell you, things like the pre-existing limitation, covering children to age 26, no lifetime limits or annual limits, certainly all of that won't decrease our costs. If you're insured, the insurance carriers will dictate what impact that has in your premiums, and we're doing some studies and analysis now. We'll be getting back to you with that feedback. If you're self-insured, the impact will be, of course, maybe on your claims costs, potentially on reinsurance premiums, maybe administrative fees, and those would be on top of what our normal trend or adjustments in pricing. So we don't know exactly yet, and it's really, some of those things will be very specific to your plan, because a lot of plans, maybe some plans don't even have pre-existing limitations today, or you already cover students or your children to age 30 or through age 26. So again, I don't want you to get concerned yet because there's not a one-size-fits-all pricing impact, but I'll tell you, with this first year, I'm going to guesstimate 1 to 4%, from an estimate of a cost increase. 1 being on the low end, 4 hopefully being on the high end, and what we'll do is we'll help summarize those impacts, separate out what was your normal increase, and then the impacts of the reforms. Starting in 2014, again, those are some models that we're looking at. We're just not sure yet until we get a lot of clarification on those changes. So with that, my component is done. I'm going to turn it over to Brian. Thank you.